Welcome. My name is Mateen Shaikh. I'm an assistant professor of statistics and data science within the Department of Mathematics and Statistics at Thompson Rivers University, which is on the traditional lands of Tk'emlúps to Secwepemc within Secwepemc Ulu, the traditional and unceded territory of the Secwepemc. This presentation is part of a series called Tap Into Research, which has moved online for obvious reasons. And it's part of those reasons that I'm actually here. I wanted to use this opportunity to explain and unpack a few of the values, the numbers, the proportions, and the information that's being provided on a fairly regular basis. There's a lot of people who are hearing these numbers, not really sure whether or not they should be taking something away from it, and there are some people who hear these numbers not really knowing what they're supposed to mean. If you've been following the media and have a good idea about what they're saying and can understand the numbers, most likely this presentation isn't for you. This is really for people who are just confused at all the information that's being thrown at them. This presentation is going to be broken up into a few pieces. First, I'm going to talk about some common numbers that are tossed around, in particular with conditional probabilities. I'm then going to move on to that epidemiological curve that you hear so much about. And then I'm going to end things off talking about a recent update that was provided by the Public Health Office last week, and where we can see things going in the future based on the numbers and what the numbers are going to be indicating in terms of the path that we can take forward. The first thing that I wanted to mention is something that's shown in the first slide. It's a way of describing proportions, and it's similar to Venn diagrams, and it's using rectangles instead of circles. What I really want to do is get at the idea that a lot of people have heard that the majority of deaths come from elderly people. But if an elderly person catches COVID, there's only a low chance that they die. It sounds like a bit of a contradiction, and I want to explain why it's not a contradiction. Unfortunately, the confusion comes from a very subtle choice of language when you're describing it. When you are used to this quantity, which is called a conditional probability, you end up understanding this and you get used to knowing which way things are said. However, if you're not used to this or you're out of practice, it may sound like somebody is saying one thing, another person is saying something the opposite. So I want you to look at this next diagram where I've put a dashed line around the people who are elderly. Of the people who are elderly, imagine what proportion of that box is overlapping the box corresponding to deaths. It's less than 50%. So from this, we would say that the probability that an elderly person passes away with COVID is less than 50%. This is a little bit different than stating things according to this diagram. Focus on people who had passed away. Of the people who had passed away, i.e. looking at this box of people who had passed away, how much overlaps the elderly versus the young? Or what proportion of this box corresponding to patients who passed away correspond to the elderly? You can see most of this box corresponding to the patients that passed away is made up of the elderly. That's the difference. When we talk about conditional probabilities, we're always talking about one set or one collection with respect to another set. In both instances, when we're talking about the death of elderly patients, we were talking about that number that overlaps deaths and elderly. However, when we were describing that number, we were describing it with respect to the original box of elderly patients or to this box with respect to patients who passed away. Depending on how you're creating that ratio, and when you actually do this mathematically, you're making a division, you're creating a fraction. The number that's on the bottom is the number that's changing, and if you change the number on the bottom of a fraction, you can change the value of the fraction quite a bit. This is why it may sound like you're receiving contradictory information. You're really not. A lot of people who are listening to this and are comfortable with conditional probabilities, are comfortable with sets, or you might be a student in high school, this is going to sound like something that should be obvious. But when you've been out of school for a while and you're not used to working with numbers like this is something that can end up being confusing just because you're out of practice. So I wanted to bring that back to people's attention. There isn't a disparity and there isn't a contradiction being discussed. All that's happening is that there is a subtlety in the language corresponding to different quantities. What I'd like to discuss now is an epidemiological curve. This is something that I'm sure everybody has been hearing about quite a bit. On this slide, I've shown an example of an epidemiological curve. In mathematics, this is an example of a type of a curve called a sigmoid. This represents the total number of people that have contracted the virus within a population. At the very beginning, very few people contract it, then many people begin contracting it more and more, and then the total number of people that have contracted the virus levels off again. It levels off because of one of two possible reasons. First, the virus spread, and everybody ended up sick. Everybody either succumbs to the virus and passes away, or develops an immunity. Either way, by the end of it, there's no one left for the virus to infect. That's one possibility. The second possibility is what we're doing right now. We are preventing the virus from reaching those susceptible people. That's the other way the number of people can level off. Now, this curve that you see here isn't exactly the curve that you're used to seeing typically in the news and the media. Instead, you see a function that can be plotted that's related to this. It is equivalent to this curve, and it's just giving that information in a different way. This curve focuses on the total number of people up to a particular time. Instead of talking about the total number of people that you've seen that get sick or have contracted the virus, you talk about the total number of people that currently have the infection. You do not include the people that have recovered. If you do that, you end up with this other curve, which is something that I think you're more familiar with. Again, at the very beginning, very few people get sick, but then as the virus spreads, more and more people get sick. But then once there are fewer people for the virus to spread to, either because those people have developed immunity or passed away, or because we've done things like taking the measures that we have right now and physically prevent the virus from jumping to those susceptible individuals, the number of people in the population that have the virus ends up dwindling. This is also one place where I'd like to make one little correction that the media has been sort of perpetuating a little bit. And it's really only a minor nitpicky point of view, but as a statistics instructor, it drives me bonkers a little bit. The peak does not correspond to the 50% mark. It's realistically closer to 35 or 45%, which, I mean, if it's close to 45%, it's close to 50%, and I can understand that, but it's possible that that peak only corresponds to being 1/3 through the pandemic. And that's sort of the other thing that can cause a little bit of confusion. If you say, and suppose it was true that it did represent the 50% mark, does that mean it's 50% in terms of the time for the pandemic to go through, or is it 50% of the number of people that will get it? And it's supposed to be, and when we say 50%, or when I say 30%, or I say 45%, I'm talking about the number of people that will eventually end up getting the virus. So the peak corresponds to about 35, 40, 45%. The actual 50% mark is somewhere to the right. And the longer the pandemic goes on past the peak, the further to the right it ends up becoming. And I wanted to clarify that because it could be a little bit confusing and disheartening for someone to realize that we've reached the peak, but that is not the halfway point in terms of the time that this pandemic is going to be sticking around. We've been going through this for a few months. If we happen to reach the peak today, that doesn't mean there's only a few more months left until the virus is gone. That is not how this works. The next thing that I wanted to mention is that this curve is only one of several possible curves. Depending on a variety of factors, mostly depending on something called the reproductive number, the curve could look very different. And I've shown several examples of that here. On the far left is an example of a very high reproductive number. The reproductive number is high, and that means that many people get sick quickly, and then there's no one left to infect, and so the number of people that get sick over time diminishes. If the reproductive number is smaller, if populations are larger, and so on, you can end up with a variety of different curves. If the reproductive number is smaller, generally the peak will be smaller, and the longer the pandemic happens to be. Now, I've mentioned the idea of a reproductive number a couple of times, and I might as well define it here. It's exactly what you think, actually. If you think of a regular population, the reproductive number is, on average, how many offspring does a person have? The reproductive number for a virus and from a particular host is how many new hosts has the virus infected, and those new hosts are then able to then infect other people. That's the reproductive number. So for example, if the reproductive number was 3, then one person would infect 3 people, and then those 3 people would each infect 3 new people for a total of 9 people 2 generations later. That's the reproductive number. You can see that if the reproductive number is a number greater than 1, the population will spread, and eventually it ends up spreading throughout the entire population. If the reproductive number is less than 1, so on average, a person has less than 1 child, the population will start shrinking. And that's kind of what we're trying to do with the measures that we have in place. We're trying to keep the reproductive number less than 1. We're trying to make sure that the virus diminishes in its presence in the population. One other thing I'd like to point out with this slide is those right 3 curves. In particular, I want you to look at how those curves start. They all start the same, or pretty close to the same. Now imagine somebody was going to hand draw one of these curves. You wouldn't know whether they're drawing that pink curve, that green curve, or that purple curve. So when we are drawing this curve that I'm showing you here, and let's say we're at the very beginning, we don't know where the peak is going to be because we really don't have a sense of where the rest of the curve is going to end up. That's where some of the uncertainty comes from. Now, before I go into where curves are projected, I'd like to talk about something that's extremely important about what we can do to this curve. This curve represents the number of active cases in the population. It can also represent the number of hospitalizations. It can also represent the number of deaths. These curves are related to each other in that they generally get smaller and smaller as you go into more serious and less likely scenarios. But they all have this generally similar shape. Now, I think everybody has seen some variation of this where we have some line that represents typical hospital capacity and then something called expanded capacity. If we were to do things like cancel elective procedures, then we can free up beds. This doesn't mean willy-nilly, silly types of things to be doing in a hospital. Elective procedures are things like giving organ transplants or removing tumors from people. These are things that are essentially non-emergency urgent scenarios. We're choosing not to schedule things in advance. We're only looking at emergency scenarios and keeping beds open for emergency scenarios. When a patient is going down a really bad road with COVID, they're having trouble breathing, that's an emergency. So that's why those beds are being kept open for emergencies. When you keep those beds open, you can open up the number of beds, and so you can accommodate more people. In this graph, you can see that we're still going past the number of people that we can accommodate, even with the expanded capacity. So people have to do their best to try modifying the reproductive number of the pandemic. And by doing that, they're shifting the curve, and we jump from a curve that started off like this to another curve that ends up being shorter but drags on longer. So this is an example of taking on severe population measures that we've been doing right now. Canceling school, having people stay home as much as possible, don't go to the grocery store unless you need to, things like that. There's two things to keep in mind here. First is that obviously the peak is below the capacity, which means that we're not going to run out of beds in the hospital, which is important. The other thing to keep in mind, and it's not just a coincidence that it's drawn this way, the length of the pandemic is necessarily longer. The reason is the reproductive number is tied to the length of the pandemic. If the reproductive number was very close to zero, basically it doesn't transmit, then it fizzles out and ends very quickly. If the reproductive number is very, very high, let's say the reproductive number was 7 billion, then everybody on the planet got sick next week. But then a month from now, everybody has either succumbed to the virus or become immune. Either way, there's no one left to infect, and again, the pandemic would have ended. If the reproductive number was close to 1, then we get almost the same number of active cases week after week, month after month. That's the case that drags on the longest. We're willing to do that because we don't want to run out of hospital beds. The reason why we don't want to do that is just like we can jump from one of these epidemiological curves to the other epidemiological curve, namely the one that has a slower peak, if we didn't do that, we would still jump to another epidemiological curve, but it wouldn't be by choice. Here's an example of it. The pink curve is the number of deaths that you would see if you never ran out of beds. The gray curve is the number of deaths that you would see if you do run out of beds. Once you reach capacity, you jump from one curve to another. There's a bend and the number of deaths goes up. And I've drawn an arrow here that says that the difference in the heights corresponds to the number of deaths that you would not have had those people had beds. Put somewhat more harshly, these are preventable deaths. These are preventable provided that we can give them the hospital equipment that we do have. We just have to make sure that it's available. So that's why it was so important to make sure that the curve did not peak above capacity, even at the expense of delaying and extending the duration of the pandemic. It's uncomfortable, it's not fun, but people are not dead because of it. At the very least, preventable deaths do not occur. And that's really the point of all this. We want to prevent as many preventable deaths as possible. I think a lot of people are comfortable with this idea in terms of understanding it, although it's a terrible thing to think of, so I'm not going to dwell on it anymore. What I'm going to talk about now is the actual data that's been coming in with BC. This is a slide that was presented by BC CDC from the PHO last week. If you look at these numbers, you're naturally going to want to try matching this to one of those epidemiological curves. You're going to try to get a reproductive number out of it. Now imagine we only had the numbers up until the middle of March. And so you started drawing your line for this epidemiological model. Let's say you started drawing it around March 1st. And you started drawing it, and then you stopped right around March 15th. Or March 14th, that's Pi Day. If you stopped then, and then you handed that piece of paper off to somebody else and you asked them, complete the epidemiological curve, we're kind of back in that situation where we could be going to a really, really large peak, a moderate peak, we could be right near the peak and we wouldn't really know. And the reason why it becomes a little bit more uncertain is because you can see this is not following a super smooth process. There's uncertainty and there's a little bit of variability around the average trend that also has to be incorporated into all modeling. So because we have this extra uncertainty, you have uncertainty about which curve you are on. In addition to that, if you change the reproductive number over the course of the model, then you end up jumping from one curve to another curve that happens to be intersecting at the same spot. and then you're slightly changing the trajectory. So you end up being a little bit confused. We changed the reproductive number very dramatically in that really eventful week in the middle of March. So we jumped from one epidemiological curve to another right near the March 15th to 20th range. There were a lot of things going on. Schools were being canceled. People were being asked to stay home, things like that. So that's when we jumped between curves. So if you tried to sort of model this and figure out where we are in terms of the epidemiological curve, most people would look at this and say, at some point, there was a peak. People would have likely drawn a peak in different places, but I think most people would say we've passed some kind of a peak. It may not be the only peak that we have, but it looks like we've passed one of the peaks for at least a first wave. If there's a second wave, if there's a second wave, we're going to have essentially another epidemiological model with another one of these curves and another one of these bumps. This slide that I'd like to present is something else that was provided by the PHO in that presentation last week. It's modeling the number of critical care cases over the last couple of months. You can see that an epidemiological curve was fit at the beginning where we have bars, where we have data. You can imagine that at the very beginning of the pandemic, the reproductive number was large, but the number of cases was small. So the number of cases didn't get to spike yet. In the middle of March, we changed our behavior, we changed the reproductive number, and we switched from one of those curves to another curve. We jumped from one epi curve to another curve. And so what ended up happening was we ended up seeing what looks like might be a peak. If we continued on that trajectory and kept the measures that we have in place, what'll happen is the virus will generally be unable to reach most of the susceptible population, and the viral load in the population will eventually diminish. Had we not imposed those measures, we would have followed that path where the number of cases would have gone very high, and the reason it declined is because everyone's already been infected and there's no one left that's susceptible to infect. Now we're at that point where we're talking about if we change our behavior again, what would happen? And the reason we're talking about changing our behavior again is because we don't want to live our lives like this forever. So we have what life was like before, where things were normal, but the reproductive number was really high, much bigger than 1. We have what life is right now. It's a reproductive number that's really low, but it's not a very pleasant life. And we have that magical number 1 in the middle. Every epidemiological curve where the reproductive number is less than 1 going forward, on average, generally corresponds to the virus fizzling out in the population. The closer it is to 1, the longer it'll take to fizzle out, but it will fizzle out. All of those cases of the reproductive number being greater than 1, where if we relax measures so much that the reproductive number was greater than 1, then the virus would again have a chance to proliferate and would likely end up reaching everybody in the population, which undoes all the efforts that we've been doing up until now and makes as much sense as nipples on a platypus. So what we want to do instead is make sure that when we increase these reproductive numbers and increase our measures influencing the reproductive number, we make sure we don't cross that line of an average reproductive number of 1. What would likely happen in many scenarios is we'll create this continuum of steps. So slightly relaxing things like we'll open stores again, but everyone still has to be 2 meters apart and there's still going to be lineups outside of stores. We're still going to have bans on mass gatherings like concerts, sporting events and big audiences, theaters and things like that, unless we're able to enforce something that prevents transmission to keep that reproductive number less than 1. The easiest way to do that is by preventing transmission. You prevent transmission by keeping 2 meters away from people. So if we can go through life, again, where everybody's still keeping 2 meters apart, in theory, the reproductive number would stay relatively low. We'd still have to do things like wash our hands a lot, and we would still try to avoid people when possible, but we could then start going out and meeting people again, go to the park with your family, provided that you're keeping away from other people in different households. Again, we're going to have a series of steps where we slowly relax, and those steps we get closer and closer to normal. Some regions are going to find that when they relax one step, they cross the line, and the reproductive number is going to end up being greater than 1. Hopefully what will happen is there will be a lot of testing being done, so we're going to be keeping tabs on what the average reproductive number is week to week. And so if 1 week we see that there's an increase in the number of cases, then we know the reproductive number was greater than 1. We've got to backtrack a little bit, wait for the number of cases to go back down a little bit more, and then slowly relax things again. While we're waiting to relax things again, we'll likely be examining what happened to see why was there transmission when we didn't think there should have been transmission. So, as I mentioned, this 60%, 80%, 100%, that's all relative to what the reproductive number is. What that means in terms of real life, translating a 40% means this or a 70% means this, that's really going to be difficult. No one's really going to know. What we're going to do is we're going to create a continuum where we just start relaxing slowly, and we'll just see how close we can get to flirting with that line of a reproductive number of 1. I'd like to move on to talk about where some of the uncertainty remains with a lot of the numbers and information with COVID. You first saw from day to day, if you were plotting a graph and you only went from that one graph that we had shown before, one day to the next, and you passed only 1 day's worth of additional information to that person next to you to try drawing the rest of the curve, that person would say, that really doesn't give me very much. And that's basically what you should be taking away when it comes to daily cases. Unless there's something very dramatically different from the previous day, you really aren't supposed to be gathering too much information. Week to week, probably something more useful to get there, because then you can actually correlate that with trends a little bit more. But there's enough variation day to day that it can obfuscate any trend that's actually happening inside of the data. So day to day, I wouldn't really pay much attention. Week to week is where you should really be focusing to see where trends happen to be, which is why it takes so long to understand what's going on. We actually have to be fairly sure about a trend over a long period of time before we can say that trend actually exists. Compounded with that is the fact that tests are being delayed by several weeks because symptoms don't show for 1 to 2 weeks. There's the other issue that some people may not be tested because they're presenting non-typical symptoms. We're usually testing people that have a lot of the classic COVID symptoms, but people are heterogeneous. People are a little bit different. The symptoms one person has might be different than the symptoms another person has. So there's definitely underreporting. It's just a matter of how much underreporting is going on. There's also the issue of asymptomatic and pre-symptomatic transmission. Theoretically, if there was no pre-symptomatic, asymptomatic transmission, and you were symptomatic immediately when you caught the virus and you stayed home, we would run into that scenario where there would be zero transmission. The reproductive number would be 0 and everything would fizzle out. Where this transmission is remaining, where the reproductive number gets a chance to be greater than 0, is in that pre-symptomatic, asymptomatic, and something that for some reason isn't discussed very much, something called polysymptomatic scenario. Pre-symptomatic means you've got the virus, you are probably starting to shed the virus, which means that you're capable of passing it on to someone else because it's now exited your cells and it's now likely in some of your mucous membranes, but you haven't gotten enough of a load that your immune system has managed to develop a significant response. So you are shedding the virus, but you don't have the symptoms because your immune system isn't on top of it yet. That's pre-symptomatic. Asymptomatic would be no symptoms whatsoever. A lot of people are talking about asymptomatic cases. Asymptomatic is completely unreported and everything in all of these numbers and models that we're using right now. There is something in the literature about asymptomatic cases. I read something from the American CDC from back in January. They found one super spreader that was an asymptomatic person. Everybody their cases were traced, and everything pointed back to one person who just wasn't sick. And they ended up testing that person. That person had COVID. They were completely asymptomatic. So an asympt can pass something on to other people in some cases. A lot of people are worried, well, how much of the population corresponds to asymptomatic people? And I'm not as worried about the asymptomatic population because it's likely not as big as people are thinking. What's likely happening is that there is a group of polysymptomatic people. Polysymptomatic means that they have fewer symptoms. So it could be something like, instead of having a fever, a cough, shortness of breath, you've got a mild fever and a little bit of fatigue. Some people regularly get a little bit warm and tired just in their everyday lives every few weeks. So a lot of people just shrug it off and don't even know that might have been your symptom. So you were technically symptomatic. You were technically, if you were warm, your body was likely starting to mount an offensive, which means that the virus was shedding, but you didn't recognize that's what the case was. So there's probably a lot of polysymptomatic cases. From your perspective, you're asymptomatic because you didn't recognize the symptom. One of the reasons you don't recognize the symptom is because we're not saying all these possible things could possibly be symptoms. You can imagine what the pandemonium would be like if everybody who was tired insisted on going and getting tested. That just isn't feasible. But being tired might have been the symptom for having COVID. It's a very mild case. But those are the people that could be going out and spreading. So there's now talk about wearing masks. Dr. Tam, Theresa Tam, was very reluctant for many weeks to say anything about masks. Last week, she finally said it's probably not a bad idea to wear it if you're asymptomatic. If you don't have any symptoms. If you have symptoms, you shouldn't be leaving at all. But if you don't have symptoms, wearing a mask might be helpful. One of the reasons there was a little bit of friction against that idea is because we don't know how effective masks are. And I'll give a quick little logical explanation as to why you may worry about it. One thing that she had mentioned over and over again was if people who aren't used to having something on their face suddenly have something on their face, and as you're walking around, it's probably sliding up and down, it's slightly irritating your skin, it feels itchy, so you're likely going to start scratching. That's what she was talking about. What I'm personally concerned about, and I don't think a lot of people have mentioned, is we're in the middle of allergy season now. So some people are going to be coughing and sneezing from allergies. They're not sick, but they have allergies. And it's not until their first coughing and sneezing fits that they realize they need to start taking some allergy medication. So they're out and about and they start coughing and sneezing. When you cough and sneeze into a solid object, that air has to go somewhere. That air is going to go out to the sides or up and then maybe settle on someone else. That's a terrible thing to do. That will likely increase the average reproductive number of a person wearing a mask. I don't know if it increases it beyond 1, and so a person is more likely to infect a variety of other people. In theory, if you're maintaining a 2-meter distance, it's all a moot point anyways. But if we're talking about letting people take the bus more because we're going to let people go back to work, they're still going to maintain 2-meter distances, but people are going to be sneaking past people in lines, and people are going to be sitting next to somebody on a bus or sitting next to somebody on an airplane. If you're wearing a solid object in front of your face and you cough and it just goes out the sides, and if you're on an airplane, you're now increasing the risk of the people sitting next to you. That's a terrible, terrible thing to have happen. So if you are going to be wearing a mask, what is oddly likely a good thing to do is have it somewhat porous so that a little bit can get through. But the best thing to still do if you're wearing a mask, especially if you're wearing a mask, is still practice sneeze and coughing etiquette where you're in the crook of your arm and you let this part of your elbow cover the sides of your face so that it's not going out to the sides. Don't create a perfect seal because that air needs somewhere to go. You're allowing it all go straight down into your lap. That's not going to get anyone sick. It's possible it'll go down into your lap and sort of spread on people's hands, but those people should be washing their hands a lot, maybe carrying some hand sanitizer if something like that happens. But it'll at least prevent people from coughing and sneezing to the point where these droplets have an opportunity to directly make impact against the mucous membranes on the face. Going forward, we're likely going to be exposing ourselves to more opportunities for transmission, so the reproductive number is necessarily going to go up. We're going to hope that we keep it less than 1, but we're going to have to work with a world where we're going to still physically be far apart from each other. If you go to the movies, you're likely going to be sitting every other aisle, because remember, if you put your arms out and somebody else puts their arms out, you should not be able to touch fingers. That's how far apart you should be. So that probably means 2 seats to your left, 2 seats to your right, the seats in front of you, the seats behind you. That means in a radius around you in a regular movie theater, that's probably 8 empty seats. So the theater is going to be operating at 1/8 the number of tickets, but still the same expenses. That may not be feasible, so they may not open. For the same reason, a lot of sports events where you're sitting in a giant stadium or something and you're close to people, you're only going to allow 1/8, 1/10 the number of people in. That may not be financially feasible, so it may not have an audience. What I think would be kind of fun is if we had drive-in movies make a bit of a return. Have that for all your sporting events and people just drive in and watch from inside of their car. I think that would be kind of fun. But it's still something that we have to keep in mind when it comes to maintaining distance. Everything we do has to ultimately come down to keeping the reproductive number less than 1. The physical distance that we keep, that radius that is outside of the expulsion radius of droplets when you cough, sneeze, talk, whatever it happens to be, 1 to 2 meters, we need to maintain that. If in some instances when we relax these conditions, we're not maintaining it anymore, we need to have other measures in place. And we don't know what those measures are going to be. But I am hoping that we're going to slowly create several steps that we could be taking and essentially create a continuum where we know if we did all of these things, the reproductive number would be greater than 1, but we can play with which one of these things that we can allow without letting the reproductive number grow past 1. For example, we could allow stores to be open again, keeping everybody apart. We could allow people going on public transit if they wear a mask. Maybe we don't allow both of those things at the same time. Maybe we allow one of those things. Maybe we allow one of those things, implement the other one, and if we're testing very frequently, we'll know that the number of people who were sick the week before, the number of people who are sick several weeks later, if the average reproductive number ended up being more than 1, i.e. the number of cases went up, then we know we have to scale back some of those, but not necessarily all of those measures back to normalcy. The more of those measures that we have, the more individual steps that we have, the more we can keep when we need to scale back. So that's why it's a good idea to make this a little bit complicated. I've enlisted with the government to help with a way of scaling things back to restarting the economy. I'm not going to mention anything about that here because it's going to be up to the government to decide whether or not they're interested in that. But there are a lot of good ideas floating around about how to get back to normal. And everybody's going to try something a little bit different. Some things are going to work, some things aren't going to work. Some things are going to work for the wrong reason, some things are not going to work, and that will be a fluke as well. So it's going to be a bit of a learning process, and there's going to be a little bit of growing pains. But when we go back, it's going to start being very heterogeneous across the country. There are some provinces that are going to be ready for it whenever it happens to be, and other provinces that are still waiting for their peak. And so it'll end up being less of a single province standing still and some pieces of the country starting to move forward again. Where I'm likely going to end up helping is, again, talking about those numbers when it comes to what is the total number of people actively sick at any period of time. We have the asymptomatic people, we have the pausymptomatic people, we have the pre-symptomatic people. That's obviously causing an underreporting. My personal research involves, in some instances, missing data. Still getting the right answer when you've got missing data, in particular when you've got missing data that is likely very related to the numbers you're interested in. A fun little story that I'm sure a few people have heard about. It was about World War II. Her Majesty's Navy was sending out bombers and very few were returning. So they asked for an analysis to be done on the planes that did return to figure out where do we need to put more armor. We can't just put armor everywhere because then the bombers end up being really, really heavy and then they have to carry less bombers, which is not very useful to anyone. So if they take less bombs, we aren't going to be very happy. We need to find a way to optimize the armor while still keeping a lot of bombs inside of the bombers. And so the statistician was going to be called to help, sort through what all of this happened to be. There were a lot of planes that had bullet holes in different areas, and it was the statistician's job to decide where it was on average that we needed to put armor on all of the planes. Statistician's name was Wald, Abraham Wald. He was a Hungarian mathematician, actually, but his day job was a statistician, and obviously he wasn't in Hungary during the war. He had moved over to the Allies. He came in, looked at all the bullet holes, and saw there were bullet holes basically riddled around the fuel lines and the fuselage, 2-3 per square foot. And around the engine, there weren't that many bullets, maybe less than 1 per square foot. And he took down information about all of the individual planes and churned through all the numbers. He came back and the Navy said, all right, where do we need to put all the armor? And he said, do you see where there aren't many bullet holes under the engine? And then here, there's a lot of bullet holes near the fuel lines. Put all the armor where there's no bullet holes. People were a little bit confused by that. And he had to explain. The reason is we've got an observation bias. We're only seeing the planes that are making it back. There's got to be something different about the planes that don't make it back. A reasonable thing to think is maybe the only reason these planes made it back is because they weren't shot in the engines. All of these planes had a dearth of bullet holes in their engines. So they ended up putting all of the armor, or most of the armor, around the engines. And more bombers actually started making it back. Not all, but more started coming back. So that ended up being useful. It's somewhat related to what I do in my research. I look at where there's a lot of missing data because the missing data can be informative. I'm personally interested right now about what the hospitalizations happen to be in terms of the demographics. What kinds of people are being hospitalized? Because from that, I want to make a really good guess as to the people who are not being hospitalized. And if we can find out the people who are not being hospitalized, maybe there's something that we can tell those people about whether or not they're asymptomatic or pausymptomatic, and maybe those people need to be on even more guard than anyone else. I hope you found this presentation helpful in elucidating what a lot of the information that you're being given on a daily and weekly basis for several months now happens to mean. There are some people that are a little bit curious and they start trying to find more COVID data, and they find that's about as easy to find as goose without manners. But a lot of this information that you find can get confusing quickly. I hope that you have a better understanding of what a lot of these quantities happen to be, the information that we're being provided, and I'm hoping that there's a bit of an appreciation for the epidemiological curve, why it's essentially dictating policy at this point, and why there's so much uncertainty in trying to estimate the reproductive number and trying to actually figure out which epidemiological curve we happen to be sitting on. There's a lot of uncertainty that goes on inside of data, and that's really where a lot of statisticians come in. I'm really happy that Thompson Rivers University is launching a new Master's of Data Science this September, and so you can bet that there are going to be a lot of people with some pretty advanced skills working on these kinds of data going forward. I'm looking forward to working with the government on trying to help wherever I can. I hope that for the remainder of this pandemic, when you hear this information, you actually get a sense of what that's actually supposed to mean to you, and it means exactly as much as it should mean to you, and it doesn't frighten you very much. I hope that you stay safe for the remainder of the pandemic. Thank you for your time. Take care.